Hello, everyone, and thank you for giving me the opportunity to do this remote recorded lecture. But I'm very happy to be participating in the educational program. This has always been one of my favorite programs at Mount Sinai, and I thank everyone for participating in it. What I'm going to talk about today is something which has begun almost completely so far in inpatient medicine, but I believe it has a lot of implications for cardiologists and will move from inpatient to outpatient, and that's the use of artificial intelligence in the form of clinical decision support. And I'm going to give some initial successes and future directions. And Newsweek rates the world's best smart hospitals, and Mount Sinai has been rated as number 5 in the world in both 2023 and 2024. Now, this is last year's rankings, and I think it's the same this year. I think Morningside is still around 28, which is one of the other Mount Sinai hospitals. And I was just trying to reason and think why we might have been rated higher. And I think a lot of it has to do with our implementation of more advanced diagnostics using AI and these clinical decision support tools, which I'll be going into in greater detail. So one of the first things that they cited when I first looked at U.S. News in 23 was that we were using digital imaging relationships or digital imaging vendor relationships. So if we look at Viz AI, which is a very important entity for automated analysis of radiology images, you see that Dr. Jay Mako of Mount Sinai is involved with them and helped them develop their tech, especially as it related to diagnosis of lesions that qualify for thrombectomy to prevent a stroke or to treat a stroke. And then when we look at AI Doc on the right side of the screen, what you see is that these technology partnerships also include Mount Sinai, and they've done work that's been very helpful in doing things like automatic recognition of, I think, pneumothoraces and various other radiology findings. And they've been proven to be very, very accurate. So I'll stop right there. But I think digital imaging vendor relationships do inure to our benefit in certain circumstances, but having worked a lot with our information technology partners over the years, every time we implement a third-party solution, it's a lot of additional work. Very good. So I'm going to move on to the next slide here. I'm sorry about all those little circles. And now let's talk about digital innovation in the hospital room, at the bedside. And this is also happening in the ambulatory world with people's smartphones as well. And the digital whiteboard at the foot of a room is a way to communicate effectively with patients. And as we're trying to improve outcomes, a lot of this has to do with communication of patient through the patient care tablets and MyChart, which is what Epic uses, which most of us are now trying to label. So we call it My Mount Sinai. And so it does everything from bedside and meal ordering, but most importantly, empowering patient experience, education, and communication with staff. And one of the things that we hope to do in the future is to push out information to our patients through these tools using smarter algorithms. Now, we have a growing portfolio of artificial intelligence tools that are in production in the inpatient setting. So I will go over a few of them, specifically malnutrition, clinical deterioration, which would be someone who's having a cardiovascular, cardiopulmonary, some other sort of deterioration that leads them to require critical care. And then I'll just spend a little bit of time on what we did during the worst of COVID, because I think it was a real success story, how we were able to build partnerships and show that data science does not have to be slow, especially in a clinical emergency. So in the pandemic period of greatest stress, the spring of 2020, we had several initiatives with industry partners. For example, Intuit came in and helped us with the user experience for our clinicians. They facilitated the design for what I'll show you in a future slide, which we called our COVID 360 dashboard. It helped us decide on the resources that we needed to have. Google helped us develop a purpose-built remote monitoring console, and it was basically Google Nest cameras that enabled us to communicate with people in the room without burning through a lot of PPE. There was no AI with this one, but I thought I'd mention it anyway. And then Goldman Sachs came, and they did a tremendous job helping our AI projects move from research into hospital operations by helping us with a lot of architecture work that had to be done. They were just fantastic data engineers. And then finally, Microsoft Azure was very good for us. They gave us free credits, if you want to think of it that way, to use the cloud to deploy our algorithms. COVID 360. Well, it was pretty bad for all of us in the spring of 2020, and New York seemed to be the epicenter of the epicenter at that time. And it was very important for us to have an idea, as the hospital was being overwhelmed by patients, who was likely to do well and who was likely not to do well. And in that particular period of time, you see that we settled on four things. Likelihood of discharge within 72 hours, because we had to manage the beds and we had to have an idea how many units we had to convert to isolation units. How likely the person was to require intubation in the next 24 hours. Think of that as a clinical deterioration. How likely are they to require ICU admission? And then finally, how likely are they to require dialysis, which was a very, very bad prognostic indicator. And then this is an example of a patient who was destined not to do well. And you can see that the 72-hour discharge rating was quite low. The patient was already intubated in the ICU with a high likelihood of requiring dialysis. And then I want to point you to something which we developed with Intuit, which was when we had these predictions, we also had the ability for the clinician who was observing them to give us a thumbs up or a thumbs down. So in other words, if this had gone on for much longer, we would have had a version 2 and a version 3. And one of the things that we're going to come back to is that engaging the end users, the clinicians, in deciding whether something is a good thing or a bad thing in terms of a prediction is very helpful. So if you are a bit of a nerd related to the predictive algorithms, and many of you are as cardiologists, you've looked at this many times over the years and various predictors of adverse cardiovascular events, you see that a receiver operator characteristic curve, when it is significantly above the diagonal line, which is the same as an area under the curve of 0.5, which would be an even coin flip in terms of whether your test is going to give you a true positive versus a true negative result. The predictive value of these tests are measured with an area under the receiver characteristic curve. And so looking at this, I think the point that I'd like everyone to take home is that we deployed this throughout. This particular algorithm was for predicting malnutrition. We deployed this throughout 6 different hospitals. And we were lucky in that we didn't have to run the algorithm on the data at each of the individual hospitals, because it turned out that it was consistent. That is not always the case. And so I think it's very important that you maintain a high level of vigilance related to the data integrity and to look at the predictive models and see how they perform across different segments of your population. Going to this next slide, and to the point I raised before, we need to empower our staff to improve the model. And how does that work? Well, in the case of the malnutrition prediction algorithm, the data science platform feeds the electronic medical record, and it prioritizes patients to be seen based on a predictive score. And if you look at the left side of the slide, you see that we've actually given the reasons why we've made that prediction, which is doable with many of the predictive algorithms that you would deploy these days across a wide range of platforms. And when we look at the nutrition follow-up, you see that malnutrition, where the arrow is pointing, you can click either yes or no, not at this time. And so every single time we send someone to a bedside because we think there's a high risk of malnutrition, they tell us whether we're right or wrong, and our algorithm gets better over time. And you can see that on this slide because the orange line on the left is higher than the purple line. That's called a precision recall curve. And again, back to the area under the receiver operator characteristic curve on the right, you see that the bluish line is higher than the purple line. So in both cases, looking at both of these assessments of the value of the algorithm, it got better with version 2 versus version 1. And it goes back to the key point. The clinician, whether it's a nurse, a dietitian, a physician, has to be involved in the process and engaging them and making sure that we regard this not so much as artificial intelligence, but augmented intelligence is the secret to our success. So I want to tell you about a clinical deterioration research trial that we did, that we ended right at the beginning of the pandemic for obvious reasons. And what we did at that time was we had an algorithm which predicted whether people were likely to end up in an intensive care unit within the next several hours. And what we did was we took 4 medical surgical units, 2 of them primarily on the medicine side, 2 of them primarily on the surgical side, 120 beds. And for 2 of those units, 1 medical and 1 surgical, we sent low-level alerts to nursing to increase the level of vigilance, check vital signs more frequently. And we sent high-level alerts to an ICU rapid response team to come out of the ICU and evaluate the patient. And then we had 2 other units where we generated the alerts, but we suppressed them. No one saw them. We didn't let the nurses know. We didn't let the rapid response team know. And we ran the study between July of 2019 and March of 2020, stopped early, but we were still able to enroll close to 2,800 patients. And this is a very important result here in that when we compare the relative risk of the secondary outcomes, which is survival to discharge for at least 30 days within the hospital, we see a very significant effect here with an odds ratio of relative risk of 1.39 and confidence limits that are highly significant. The primary outcome was actually something that we had some internal discussion about because the point was we were looking to see if the patient was ever escalated to the next level of care. Well, the mortality benefit probably became because we actually didn't prevent escalations. We identified escalations of people who actually needed it. And the other important thing to notice, even though it's a little hard to see on the slide because of the way it's presented, is that faster hospital discharge was also occurring. So I don't think Mount Sinai should be the only one here, but we have some things that we've done which have positioned ourselves to succeed in AI predictive algorithms. And I would encourage all of you and your organizations to think in these terms. We developed a school department of artificial intelligence of human health. We recruited a dean. We have an alliance with a group in Germany that does some extensive computing work with us. And Schmidt Futures, which is a philanthropy, is supporting some postdoctoral positions. So we're developing on the school side, on the scientific side, a data science engine. And then in addition, we have an Institute for Personalized Medicine, where a couple of our key physicians who run that are also looking very carefully at predictive algorithms based upon genomic analysis. And we need to marry the electronic medical record data, the phenotype, with the genomic data because we're now collecting up to 1 million genomes exomes that will be analyzed by a group at Regeneron. And then ongoing, so think of it as a full integration of clinical data science into what we call digital and technology partners. Everyone else calls it IT. And these ongoing alliances with external organizations also help us promote data science and engineering, and it establishes a community of people that share their results and talk a little bit about the strategies that we take to achieve success. So Sheba Medical Center in Ramat Gan, Israel has been an ally of ours over time, and we have worked together and shared some data science resources. Microsoft Azure, I already mentioned, was very generous in helping us deploy our models in the cloud. And we've even, talked to other nations about potentially implementing this. So as we move towards the end of this talk, I want to focus not just on using data in our electronic record, the classic laboratory, perhaps the natural language processing of the medical notes, but we have to move on to a multimodality world in the future. And this will be very important for cardiology because there's so many social determinants as well. So yes, within the electronic health record, we have clinical notes, we have waveforms, we have multi-omics coming, not just from genomics, but also the exosomics and the microbiome. And of course, we have imaging data. So when we integrate the multimodal data types, we can generate these rapid insights. And the idea is that the harmonized data leads to rapid development of predictive models. And then we leverage the multimodal data to develop clinical solutions. And again, it is about validation. Workflow integration is the key. We joke that we spend 20% of our time on data science and 80% on implementation science. And it really isn't such a joke, because only when the clinicians on the front line see this as a positive, when they see us bringing the right person to the right patient at the right time, that's how we define success. So as I end, the future is multimodality and also something that the FDA calls software as medical device, or SAMD. We've demonstrated our ability locally with these projects to implement rapid technological solutions to important clinical problems for us. When we identify malnutrition and we treat it, we shorten length of stay, we improve observed to expected mortality. Using technology that is informed by physicians and nurses, we can improve patient care and outcomes, experience of care, and also something that's very important to all of us these days is the financial returns and also the external ratings. All of this is dependent upon our quality metrics, and everything that we've concentrated on thus far is related to improving clinical quality. And staff engagement and satisfaction, again, I'll come to it again and again, is the key. So as we speed our journey towards becoming a learning health system, I hope that this provides an example for all of you to consider, especially in the cardiology context, how within inpatient settings, we might look for exacerbations of CHF or cardiovascular deterioration, how we might eventually look at our ambulatory populations to avoid hospital admissions or unnecessary emergency department visits by activating our teams to get there into the community and provide the care that we need to. So I hope as cardiologists that you see the applications of this, and I want to thank you again for inviting me to make this presentation.